Welcome to Variations 4, Hematology Unit. In this video, we'll be covering questions 6, 7, and 8, hemolytic anemia, sickle cell anemia, and polycythemia. So the first question, causes and management of hemolytic anemia. So if we just review this picture from your PowerPoint 32.1, we see various kinds of anemia, causes and decreased red blood cells. Obviously, there's decrease in production for various reasons. There's blood loss, but these are not hemolysis. These are just two reasons for anemia, or two classes of anemia, so to speak. Hemolysis involves the destruction, the destroying of red blood cells, and that's not falling under these two categories of anemia. So hemolytic anemia falls under this third one here, which is increased RBC destruction. We say increased because it is normal for the body to destroy a certain amount of RBCs, recycle them, generate new ones. But increased RBC destruction leads to unhealthy levels of anemia. And so you've got some various classes here. We know sickle cell disease we're going to talk about that causes them to be destroyed. Certain medications can cause destruction. Incompatible blood, this should be familiar to you because we've talked about hemolytic transfusion reactions, which are fairly serious and usually end up having us stop the transfusion and get help, because hemolysis causes symptoms and a threat to the level of consciousness and cardiorespiratory functioning, which we've seen in INP, or at least talked about. And then there's actual trauma to blood cells. Certain things like heart valves apparently can cause increased destruction of RBCs. Okay, so now if we go to the maps, just to talk about this in kind of word form, map number 2 has a nice explanation here from your textbook. Remember that when we have increased breakdown of cells, that debris, if it's in excessive form, can cause the kidneys jam up tubules in the kidney and cause failure, kidney failure. The best way to solve that, if we get to it early enough, is to flush the kidneys out with IV fluids. When I say early enough, I mean before it causes serious kidney injury. So intrinsic hemolytic anemia, that means anemia that's being caused by the body itself. We already talked about thalassemia and how we have a dysfunctional hemoglobin that causes hemolysis. Well, that's a type of anemia that's hemolytic in nature. Sickle cell we'll talk about in a minute. And extrinsic means factors outside of biology, so to speak. Like a heart valve is something that's put in there by human beings. That's a little outside of the realm of biology, but that can cause destruction, ingesting toxins, etc., medications, etc. So the next question is asking us to talk about sickle cell anemia. Again, we have this, if you remember up here with thalassemia, we had abnormal hemoglobin. Remember how we said this, these are all going to fall into some of these classes, dysfunctional components, or more than one of these classes. So we already saw abnormal hemoglobin in thalassemia. Guess what? We're seeing it again in sickle cell anemia. But the end result is different, which is why it's classified as sickle cell anemia. You've got a sickling of the RBCs. And what does that mean? If we go to our slideshow here, then you've got a normal red blood cell looking like this. The abnormal, when you have sickle cell anemia, the abnormal hemoglobin causes it to eventually, don't worry about all the middle diagrams, let's go to the end result, end up with this picture on the right, the sickled red blood cell here. It's an abnormal shape. What's the problem with that shape? It causes vascular occlusion. which yields these symptoms, signs and symptoms. Vascular occlusion has some obvious impacts. And you can read through these rectangles here, and they really should make perfect sense. If we're occluding vessels, then these symptoms and sequence of events that can happen after it makes sense. Where that could end up. Shock. The spleen can become so jammed up that because remember that removes excess cells and excess cell debris. It can become so jammed up it enlarges. That causes problems in itself, but it can also stop functioning the way it's supposed to, which is an immune response as well. And then you get increased infections. What do we do to try and help this patient out? Well, bone marrow transplant seems to be a common theme in this unit. You already talked about IV fluids. You want to manage the pain. They might need transfusions of healthy red blood cells. They might need a hormone stimulant to produce more red blood cells. And this is hydroxyurea is a med that's an anti-sickling agent. And you can read more about that, but I just need you to know that that's a med that can help with the problem of sickling, which is a sickle cell disease. And the next question, which I believe is question number 8, is polycythemia. Let's just double check that, make sure we're on track here. Yeah, so the final question for this video is on polycythemia. And so if we look at the maps again and just see what it's telling us here. Poly means many. And the essential problem is here you have the bone marrow producing too much RBCs, white blood cells, and platelets. And you might think, well, what's wrong with that? If they're healthy, what's the problem with that? I mean, you've got great functions of each of those cells. What the problem is that it increases blood volume, the amount of blood volume, and the thickness of the blood. Because remember, a large portion of the blood is usually water. Now, if we have all these extra cells, even if they're healthy cells, if we've got too many floating around the bloodstream, then it gets thicker. For example, hematocrit would probably go up. And overall blood volume goes up. It's a problem with that. Well, you've got increased chance of coagulation, therefore emboli. And you've got congestion of organs and tissues, a greater workload to move that blood around. Spleen has to work harder as it enlarges. The liver has to work harder, so it enlarges. These enlargements can cause secondary issues. We've already talked about an enlarged spleen, how that can affect the immune system, how it decreases immune response. An enlarged liver might cause some liver dysfunction. Don't worry about secondary polycythemia. We don't need to get into all that. So if we think about what we just said above, polycythemia and the increased amounts of these, the fact that they lead to this viscosity and blood volume that can increase coagulation and congests up the vascular flow, then when we look at this head-to-toe diagram, it starts to make a bit of sense, if we look at the right side first, as to the symptoms and possible complications we're seeing. Heart failure because you get increased workload. These lab results should make perfect sense. Why gout? Well, there, read through that. Why itchiness? Read through that. So you may want to use meds like antiplatelet aggregation agents to prevent the coagulations. And then this list here talks really about our treatment goals. What are our treatment goals? If you think about what we said above in these 3 goals, reducing the overall volume, reducing the overall thickness, and decreasing bone marrow activity, all make sense. You might need, so getting into more details of these three, you might need to remove some blood through a phlebotomy, around about that amount. Might want to increase hydration to decrease thickness of the blood. And you might need to suppress bone marrow with meds like this.